The broadcast is now starting. All attendees are in listen-only mode.
On behalf of the American Heart Association, I would like to welcome you to today's webinar, a case study approach to type 2 diabetes care. My name is Sarah Duckett, and I'm a Program Development Manager for the American Heart Association. Today, our speakers will lead us through 2 case studies related to diabetes care and highlight important considerations for care. Our moderators will facilitate discussion after each case study is presented. Before we begin, I'd like to quickly review how to use this webinar platform for today's event. Similar to the icon shown on this slide, you will see a control panel on your computer desktop in the upper right corner. When you join today's webinar, you selected either join by phone or computer audio. If you want to change your selection, you can access the audio menu in the control panel. Recording is in progress, with all attendees in listen-only mode. You will have an opportunity to submit text questions to today's presenters in the questions section. You may send in your questions at any time, and we will review the questions during our Q&A session after each case study is presented. Today's slides are available to download in the handout section, and you will have access to download them at any time during the presentation. A link to the recording, along with the slides, will be emailed to all attendees following today's presentation. If you are experiencing technical difficulties, try refreshing your browser, logging out, and logging back in. If these steps do not correct the problem, please contact GoToWebinar's customer service team. Closed captions are available by clicking the CC icon at the bottom of your screen. The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by AHA-ASA. The AHA-ASA does not endorse any product or device. Over the last 3 years, our moderators and speakers have engaged in an AHA initiative centered on diabetes care. This initiative, known as the Quality Collective, brought together health systems and community-based organizations across the U.S. to discuss care models and areas of opportunities related to diabetes and cardiovascular disease. The Quality Collective initiative included quarterly Learning Collaborative virtual meetings and individual quality improvement calls. The moderators for today's call are Dr. Whelan and Dr. Emerson. Dr. John Whelan is a board-certified internal medicine physician practicing as lead physician for WPP primary care at WakeMed Health and Hospitals in North Raleigh. His clinical interests are in diabetes, heart disease, preventative medicine. Dr. Whelan has spent decades helping patients manage their health in a variety of settings, including outpatient clinics in the U.S. Air Force, Duke Health System, and Durham VA. He has received recognition from the National Committee for Quality Assurance, NCQA, for diabetes care and heart stroke care. Dr. Whelan believes in helping patients achieve their personal health goals through lifestyle change. Our second moderator is Dr. Teresa Emerson. Dr. Emerson is the Chief Medical Officer for Population Health and a primary care physician at WakeMed Health and Hospitals in Raleigh, North Carolina. In these roles, she provides a system-wide oversight for population initiatives and clinical integration strategies with the goal of improving health outcomes, reducing total cost of care, and elevating health inequities. As a Park Scholar, Dr. Emerson earned a Bachelor of Science degree in biochemistry and genetics from North Carolina State University in 2001. She earned her medical degree from the University of South Carolina School of Medicine in Columbia, South Carolina, and completed her residency in internal medicine at Palmetto Health Richland Hospital also known as Prisma Health, where she served as chief resident. At this time, I will turn it over to Dr. Whelan to introduce our speakers.
Thank you, Sarah. Our first presenter today is Rana Schechter. Rana is currently the System Director of the Diabetes Service Line at Sharp Healthcare in San Diego, California. She has been working in the field of diabetes for over 30 years. She is passionate about bringing new and innovative devices, medications, and education strategies to all patients for better glycemic control and to decrease the morbidity of disease. Her clinical background includes work in healthcare systems, community clinics, medical offices, research, and diabetes device industry. Rana has an ardent desire to continue to provide patients and practitioners with the tools and resources they need to improve diabetes management and health outcomes. Our second presenter today will be Dr. Kyle Eligers. Dr. Eligers is a family medicine physician and site medical director at the Fairhaven Community Healthcare, FQHC, in New Haven, Connecticut, where he has been practicing for 5 years and in a leadership role since 2021. He completed his medical education and training at the University of Connecticut. He enjoys teaching Yale internal medicine residents who rotate through the clinic, as well as practicing primary care and addiction medicine at the Clinic-Associated Methadone Clinic and Behavioral Health Center. He has been named a Rising Star in Family Medicine in the 2023 and 2024 editions of Connecticut Magazine's Top Doctors. Now, I will turn it over to Rana to present our first case.
Good morning. Thank you. So we'll just get right into it. So the case I'm going to present is going to allow us to look at the impact of SGLT2 inhibitors and/or GLP-1 on type 2 diabetes patients and the connection between the inpatient and the outpatient care. I have no disclosures. So the case study that I'm going to share today is one of a 64-year-old female with a history of type 2 diabetes with neuropathy, dyslipidemia, CHF, chronic AFib, COPD, hypertension, and breast cancer with recent mastectomy and chemotherapy. She's about 5'5", 185 pounds, and lives alone. She was walking into a restaurant at around 10 o'clock in the morning and actually fell. She fell so hard that she was presented at the emergency department and was admitted with a right femur fracture. Her home meds included insulin degludec, 50 units BID, regular insulin, 50 units TID, empagliflozin, 25 milligrams, semaglutide, 2 milligrams per week, and Lasix. There were several other medications on her home med list, but I'm just trying to focus in on what would be looking at in terms of the diabetes status. When she was admitted, her admission labs, again, just focusing on her diabetes care. Her glucose was 185, her point of care glucose was 131, with a little bit over, but not crazy at her blood sugar as she came in. Her CO2 was 26, which is in normal limits, and her anion gap was 12, just slightly over what our normal is. We also looked and saw that her A1C was 10.8. So looking at this particular individual, obviously this is something that we are looking at past, but what we do in our hospital is we do have our physicians as on admission look at those labs that we were looking at. From a diabetes perspective, what we want to make sure of is that we look at a few other things that are happening with the patient. One would be, has she taken her insulin prior to arriving at the insulin at the restaurant? So that would be a little bit of a concern. She had a little lag time for the insulin she was using, and did she just not get to eat at all? The other thing is she takes the SGLT2 inhibitor and has not eaten since her fall. So now she's in the hospital. We don't know how long she's not eaten for. Was it since the night before? The other thing that is happening with this particular individual is she is scheduled to go to the OR for her femur surgery, and now she's scheduled for an NPO. So she's not going to get any sustaining intake at all for a while. So to back up a little bit, for the history of the SGLT2 inhibitors, several years ago, probably 21, 22, there was an explosion in terms of the data that was talking about the beneficial effects for cardiovascular disease with SGLT2s. And that was fantastic. Our hospital started looking at that, and then in 2024, as well as 2025, there are specific guidelines from the American Diabetes Association regarding cardiovascular risk. So on the left hand of your slide, what we've got is just if you have cardiovascular risk and you are looking at that patient, what they are suggesting is starting an SGLT2 or a GLP-1 initially when the person is diagnosed and they have this cardiovascular risk. They have also seen over the last couple of years, now it has been noted that any heart failure, we see a lot of benefit with an SGLT2. So many times cardiologists are going ahead and giving an SGLT2, both inpatient and outpatient. That's been very good for patients with benefit of cardiovascular disease. And then obviously, for many of you already know, the benefits on kidney have also come through. And so we are looking at people to make sure that they have an SGLT2 in terms of that. Now, what's interesting with this particular slide is that once you've been on one, it does say if it's not getting to where you need to go, you go on the other one. If you're on SGLT2, go ahead and GLP-1. If you're started on a GLP-1, go ahead and add the SGLT2. And so that was in 2024. 2025 says about the same thing. We've done it a little bit differently here, but just to, again, show you. If you have ASCVD indications and for a high CVD risk, we are really, the American Diabetes Association is making sure that we really think about either starting a GLP-1 or an SGLT2 inhibitor. And the same things that I went through before in terms of if you are not getting the benefit that you need, you can go ahead and increase the other one. What I'd like to bring your attention to is that this is a medication approach with looking at type 2 diabetes, which is all fine and great. There's a lot of benefit for cardiovascular and kidney disease. One of the things that starts to happen is that you have a little bit of a segment. You have cardiologists, nephrologists, going ahead and looking at these meds and giving those meds. Sometimes the person may or may not have somebody looking specifically at their diabetes care. They might have a primary care physician, they might have an endocrinologist, but sometimes all of that information is not gathered by the same people. So at the very bottom right of your screen, the American Diabetes Association does support that somebody would need diabetes self-management education to make sure that we're looking at all of that. And again, in October 2022, the ACC, the AHA, and the HFSA recommended SGLT2 inhibitors for treating heart failure. And now we're in 2025. So it's been a couple of years, and we're getting really great results. From the same AHA standards of care, one of the things I did want to note is that they are now, even though many of us in diabetes care were looking at, what would be the potential risk of somebody going on SGLT2 years ago. Now they're at least recognizing that we do need to be careful of, and I'll just read that first point, DKA risk in individuals with insulin deficiency. It's rare in type 2 diabetes. Discontinue, evaluate, and treat promptly if suspected. Be aware of predisposing risk factors. So we're looking at, we want to make sure that we're preventing something called euglycemic DKA. It is a potential risk, but there are ways to make sure that you lessen your risk with that particular drug. And so in general, if you do have somebody that's on an SGLT2 inhibitor and they have diabetes, one of the things that you want to do is stop use if you experience a decrease in oral intake, if you stop eating, are told to fast prior to procedure, experience vomiting or diarrhea. This can result in a condition called euglycemic DKA or euglycemic diabetic ketoacidosis. Glycemic DKA is a severe metabolic acidosis and ketonemia but blood sugars actually are less than 250. So sometimes we don't really catch it early on if you're not looking in terms of what the labs are giving you in either inpatient or outpatient. This particular DKA usually does require an ICU stay, and we want to make sure that you're looking at the trending of the CO2, the bicarb, the anion gap, the beta hydroxybutyrate to determine ketoacidosis. In general, just to make sure that this particular medication is not approved for people with type 1 because of a lot of issues, but we're looking mainly at type 2 when we're looking at a euglycemic diabetic ketoacidosis. So going back to our patient with a little bit of background now, we're looking at that for several days, her blood sugar did not go up over 300 at all. She came in on day 1, that was about 180, and then she went up a little bit. Now remember, she's in pain, she's gonna go through surgery, so that is a little bit of indication that her blood sugar might rise a little. But that we were not so concerned about that. But now looking at her other labs, the CO2 and the anion gap. On day 1, as I said, it was her first day possibly having taken her SGLT2, we do not know. Day 2, she was doing okay with her CO2 where it should have been anion gap. By day 3, and this is kind of what we say to a lot of patients, there's not specific data out there, but anecdotally, an SGLT2 inhibitor will stay in somebody's system for about 2 to 3 days after they stop taking it. So it was stopped as she came in, but she still had the remnants, and what happened to her metabolism is seen here very clearly. So her CO2 actually started to rise. Her anion gap, her anion gap and her CO2 ended up showing an acidosis. Her beta hydroxybutyrate were also showing the acidosis. So on day 3, the patient was transferred to the ICU, and we use EndoTool at Sharp, which is an IV insulin software, and that was begun. Her time in the ICU, she was doing fine with just her femur fracture, but the acidosis is what actually caused her to go into the ICU. This extended her stay and extended her, needing to be in the hospital in general. So I'm going to step back a little bit. This is a particular person that was already on it. She came in and she still had some issues. If we have patients that are going to be going ahead and going on SGLT2 inhibitors per discharge, let's say they came in, they have heart failure or something like that, we actually have inclusion criteria at Sharp hospitals where you have to be having heart failure, or you can have a CKD, and all indications in the acute care. We want to make sure that you are not started on anything until your acute illness is stabilized. You have to be taking an oral diet, and it has to be stable. You're not planned for any NPO or procedures within 72 hours. And we're making sure that we're looking at everything going on is not going to increase the risk of ketoacidosis. We make sure that their labs are within normal limits. We want to also make sure that they have got a consult for the diabetes educator. And lastly, we want to make sure that their outpatient eligibility is that they will be able to continue that medication financially, and that they've got some already set up appointments with their outpatient providers as well as labs. So we do that on every single patient that cardiology or nephrology wants to put on as a discharge med. Next slide. I just wanted to take the same scenario and give you an alternate kind of what would happen. Same woman, same everything. She takes about 250 units of insulin daily. She also has taken an SGLT2 inhibitor and a GLP-1. She does say when she finally talked to the diabetes educator that she experiences hypoglycemia a lot. Not sure why she does that. But, when she came, let's say that she was out of her home, she was not coming in for any other reason other than she started to feel fatigued. She was tired. She reduced her intake. She felt bad, but her blood sugars were not that horrible. She decided to go to the ED. She was feeling so overwhelmed by this level of illness. And she actually was shown to be admitted with the same type of thing in euglycemic DKA. So it is important that patients become aware, not just when they're in the hospital, but if they are taking these medications, they need to make sure that they're being diligent about how they need to, eat and exercise and all of that while they're taking these medicines. So at Sharp, what we ended up doing is several different things. When a patient with home meds is on an SGLT2 or beginning it in the hospital, what we do is we have an auto consult for our diabetes education staff at all of our hospitals. So we want to do that because we want to make sure that the patient understands there is a risk, although there's a great benefit, and what they need to do very simply in terms of some bulleted points. Also, upon discharge, the patient is going to be referred to our outpatient diabetes education for safety net follow-up, making sure that they are on this medication, they do understand what they need to be careful of, and also the benefits. And then lastly, if a patient comes into our outpatient diabetes center for education and they have an SGLT2 inhibitor prescribed, the education about benefits and precautions are reviewed with every one of our patients and documented. This is an example of what we give to our patients, and I'm just going to go into the very middle of that page. We want to make sure that we go over with them to reduce the chance of a euglycemic DKA. We want to make sure that you're talking to your provider and when to start and restart your medication. So at least 3 days before fasting for surgery or procedure, we want to make sure that both your physician and the patient knows that's what they should do. We want to make sure they understand if they are ill or an infection, they need to talk to their doctor, stop taking their SGLT2, as well as if they're unable to drink, eat, or if they're on a very low carbohydrate diet. This will basically further lessen your blood sugars are doing what they want, but we want to make sure that your level of acidosis is good. So one of the things, we've been doing this for a couple of years now, it's nice that we can actually see who's been getting an SGLT2 education, both inpatient and outpatient. It really has allowed both the continuity of care between inpatient and outpatient. But we are seeing some things that we really need to make sure that we are going to focus on coming up. Excuse me. Assure coding of euglycemic DKA on admission. We tend not to do that very well yet. We want to make sure there's an awareness of education with pre-op patients, especially outpatient. And then we're going to start tracking the admission and readmissions of those patients that received or did not receive the appropriate precautions. Because we want to make sure that if we're doing a great job, hopefully we're not having these admissions that are unintended. And then we want to capture the improvement of patients with diabetes and cardiorenal risk that are actually taking SGLT2s. I'm going to switch just for a few minutes here in terms of the considerations with a GLP-1. Let's say this person, it looks like she was on one of them and then got the other one. So she had both medications. But some of the things we do want to make sure of, and this is also found in the standards of care through the American Diabetes Association, is that a GLP-1 does decrease intake and appetite. So if you're using an SGLT2 inhibitor, you want to make sure you're keeping hydrated and you're making sure you're having enough carbohydrates. What you don't want to have happen is that the GLP-1 is so effective that it begins to lower your intake to a point where, I'm losing weight, this is great, but you're also putting yourself at a little bit of risk. So that just needs to be discussed with the patients. If a patient is already malnourished or underweight, we want to make sure that we're not further decreasing that intake, causing nausea and vomiting. That does happen with some individuals when they get on these meds. So we want to make sure that people are aware they do need to stay hydrated and eating. And then the other thing is, if there's a history of pancreatitis or gastroparesis, it may influence what's going on with the outcome of the GLP-1. So really why I bring all this up is that what we found at Sharp is that individualizing diabetes care and education is an opportunity to foster continuity of care between inpatient and outpatient services, especially when beneficial medications are available and readily prescribed. We don't want to have our patient in the hospital saying, I had no idea that I would get I had no idea to be careful when I get sick and stop eating and stop my SGLT2 inhibitors and call my doctor. So it seems very, very simplistic, but as many of us know, sometimes the simple education and the simple actions are what get lost when we're trying to make sure that we have our patients making sure they get their medications, they're taking them, all of that. Sometimes we want to make sure that we want to educate in terms of the things that your particular individual needs are. And I think I am done. So thank you.
Yeah, thanks, Rana. Yeah, this is a really important case. These drugs are so widely prescribed now, and seems like the indications are expanding every few months for these SGLT2 drugs. So we wanted to open this up to questions at this point for Rana. Rana, maybe I can start out. You had mentioned some of these conditions, but could you elaborate a little bit on some of the comorbid conditions in type 2 diabetes that SGLT2 inhibitors are indicated for, and what types of patients do you see them commonly being prescribed for in your clinics?
What I'll probably say this is that there's such a huge push for the cardiovascular risk is that we see people coming in. That is the first thing. If there's a cardiovascular risk at all associated with this particular patient, a lot of times that comes with an obesity risk, that they are already obese, they've got hypertension, they are just not doing well. And then obviously having higher blood sugars, a higher A1C. Usually all of those come together, which all of us that work in diabetes care knows it's just like it's the whole package. You've got somebody needing to lose weight, decrease their risk of hypertension, their kidneys are needing to be protected, as well as their blood sugar is needing to go down. So it's kind of this one particular drug. Sometimes, people think of it as the wonder drug. It's going to fix everything. And it does. It does. It has a lot of benefit, but we do want to make sure that we don't put people at risk.
Sounds good. Yeah, I thought that one figure you had, that figure 9.3 with that algorithm, kind of prioritizing on the one side, kind of cardiovascular and renal benefits, and then on the other side, weight management benefits. That obviously is on both sides. So yeah, I think we'll drop that into the chat just to, I think it's a very useful algorithm. I'm glad I saw it in your slides because I'm going to start keeping it right in my patient exam rooms. Yeah. So I don't see any questions right now. We've got a few more minutes for questions before we move on to the next case. Let me ask you, Rana, you guys seem a little ahead of the game with this at Sharp Healthcare. So what prompted you at Sharp to start monitoring inpatients on SGLT2 inhibitors for euglycemic DKA? And could you elaborate a little bit more on your process for catching these patients early?
Yeah, it's actually quite astounding. We had a cardiology department several years ago that started seeing the benefits and the research on SGLT2s and said we need to start everyone on this. And what was nice about the camaraderie between different physicians in our hospital, they pulled in our endocrinologist. And they said, we want to start using this. This is a diabetes drug. I don't know if people remember. It used to be a diabetes drug only. It was a diabetes drug. Are you using it? What do you think? And it was really nice to have that discussion of, yes, this is benefit, but with the things that I've brought up today and what is in the ADA standards of care right now is that you do have to be careful. So to appease everyone, what we did is we actually, if somebody was going to order an SGLT2 in the hospital, we actually put an order set together that there were very strict guidelines in terms of who could get it and who couldn't. And it was a combination of a discussion between cardiology and endocrinology. And we set that up and then also decided we need to look at people coming in with medications already on, all of that. And then what did we need to look at? Now, I will tell you, all of our systems are set up. But at the same time, it is literally our diabetes education staff that reviews a lot of these people on a day-to-day basis as they come in, looking at their anion gap, looking at their CO2, and they're the ones that are discovering, hey, guess what? This person is possibly going into ketoacidosis. So we've been able to catch a lot of things because our education of our own staff and our own medical staff started several years ago. Now it's nice because we can look at things and go, bingo, that was it, and then we move on. And that's when we put our education together as well. And we just thought it was really going to be very important to have the education for every person with diabetes coming in to make sure that they understood the significance. Because when it first came out, we had a lot of cardiologists that were just giving it. And if you were talking to a cardiologist, you'd be like, are they decreasing their insulin? Are they decreasing their Lasix? Are they doing anything else? And cardiologists are like, So it's been nice that over the years, we've kind of come to this point where everyone understands the definite benefits, but also potential risks.
A couple of audience questions before we tie yours up, Rana. One question is, what criteria will or should we use to combine metformin and GLP-1 agonists with, I guess, without the SGLT2 inhibitors?
I think, whatever your practice is, metformin is still out there. A lot of people use it, and it is in combination with, I think you just said GLP-1. And I think it just becomes an individual practice in terms of how somebody wants to do that. Again, just making sure that, and in our hospital, we don't necessarily use metformin as an inpatient drug. We only do it on the outpatient side. So that's kind of where it probably most likely is. If they were on it, they're probably going to be continued on it from a discharge standpoint. And then our outpatient, in our outpatient arena, we actually look at, is that all something that we want to have the patient continue on? And again, having the patient understand, what are these drugs actually doing? What are they doing to help their overall risk, their benefit, and then how are they working together? So yeah, there's so many drugs out there that just kind of everyone throws everything at everyone, and we're really kind of, possibly not using a few more drugs than we need to for a lot of patients.
Right. I think that algorithm kind of outlines it nicely. And I think this is independent of glucose lowering, is one of the points in the guidelines, is that you're still trying to add these drugs to maximize cardiovascular risk reduction and kidney health as well, regardless of glucose control. And that combination is generally safe for also avoiding hypoglycemia. So, so yeah, that's a great question. Last question I think we'll get to here before we transition. Would a workup considering late onset autoimmune diabetes be considered in patients with euglycemic DKA, or is this drug induced?
So that's interesting. We have so many people that are LADAs that are coming, have been identified these days. I think what happens is it's not necessarily drug induced. It's going to be what's happening with the patient. But I do feel, and I think what we do this at our hospitals and our outpatient, if we really feel that it is not necessarily drug related in terms of somebody going into DKA and that it's something else, we're going to make sure that we do those workups for people to make sure that we understand what's happening with that patient. So I think it's a great idea to always work up somebody for what we think that they need, that they are. We can't just assume anymore.
Especially, and especially their first time in a DKA, certainly.
Exactly.
So, okay, well, I think at this point we should transition over to Dr. Amerson and Dr. Elliger's presentation. Thanks for the questions.
Okay, everybody. Thank you so much. My name is Dr. Kyle Elligers, and I will be presenting our second case here today. I'll put my timer on here so I stay true. So this is how unfragmented or whole person comprehensive team-based care leads to direct benefits in type 2 diabetes, a case study. No disclosures. So whole person team-based care. The example we have here at Fairhaven Community Healthcare is something we call the Diabetes Health Equity Clinic, which is an example of person-centered care that incorporates the biopsychosocial model using all available resources at the clinic, including the medical provider, nursing support, social work, an integrated pharmacy with delivery capabilities, and access to other resources, including behavioral health and community programs. So let's take a look under the hood here and see what exactly makes up this health equity clinic and what makes it whole person and team-based. So what you can see here is really a one-stop shop where there are clinics we hold that have late hours to meet the patients where they are in a way that we can get most of the people they need to see and talk to under one roof. We also do have the capability to have them seen asynchronously during other periods, but the fact that we're able to unite all of the diabetes-focused providers and support staff under one roof really makes the patient feel like they have a real team that they can turn to. And if they need us to rely more specifically on one, say the endocrinologist or the diabetes health educator or the pharmacist for more increased education, or the dietitian, they have those people to reach out to, as well as care coordination and social work. As we will see, some of our patients, the social work and care coordination aspect of their care really is the linchpin in getting them to their appointments and being able to afford their medications. So why the case for whole person care? You can imagine it philosophically that the whole person should be taken into consideration. What does that mean? Well, there is evidence for this and encouragement from the scientific community for comprehensive management of cardiovascular risk factors for adults with type 2 diabetes that goes beyond just what happens in the office, right? So you see here in the middle, we have kind of the details, including what we just talked about, SGLT2, GLP, lifestyle. But at the bottom there, you see there's a whole aspect of the patient's care, their profile, their social determinants of health that will really determine where they can enter and how they can understand what resources are available to them. So it has to be addressed. So that was kind of the whole person. And now we also say, well, what's the case for team-based care? What does that mean? So here's a recent paper in the last few years that shows that ambulatory care fragmentation increases the risk for hospitalization. So having highly fragmented ambulatory care or a usual provider outside of the care, in this case, outside of the Veterans Health Administration, increases the odds of hospitalization among veterans with diabetes. So this is direct evidence that the team-based approach really does decrease complications and risk for hospitalization. So now let's take a look at our patient here and how we applied team-based whole person care to them. So this is a 43-year-old man establishing care with a clinic for primary care and a concern for unintentional weight loss in April of 2022. The workup revealed a diagnosis of type 2 diabetes with a non-fasting glucose of 496 and an A1C of 13.2. And there's a lot of obstacles for this patient. History of gunshot wound, the back, blow to head and fisticuffs, concussion with traumatic brain injury, idiopathic scoliosis with a rod replacement, chronic pain in the back and bilateral knees, chronic alcohol use, screening positive for economic need and lack of access to transportation. So supplemental security income claim previously declined, and also a father of 2 children with autism spectrum disorder. So putting all that together is quite a puzzle here, and you have to think, where do we start? So how to make peace with all these pieces. So great things are not done by impulse, but by a series of small things brought together. So we need a patient-led, whole-person, team-based framework. And Van Gogh's sunflower then turns into, ta-da, the goals of care. So this came out from the Management of Hyperglycemia and Type 2 Diabetes 2022, a consensus report by the American Diabetes Association and the European Association for the Study of Diabetes. Next slide. It came, and you can see this is in the background of the entire holistic person-centered approach to type 2 diabetes that also includes the details of the ASCVD risk and all these other medications that we're talking about. So I made my own little icons here so that when we go into the actual case, you can see when did we apply all of these different considerations for the goals of care. Next slide. And this was just in this particular case, what I thought was in order of decreasing order of contribution to the case, how we took these principles and applied them all to this person in this approach. So at the top, I think we really did a fantastic job of diabetes structured education and support, but all the way down, using all of these principles of care, we utilized them in meeting where our patient was and taking care of the whole person. Next slide. So this is the case. And I'm going to say that there are some typos here. PowerPoint, I don't know if it was because of the European flavor that I had from Van Gogh, but it kind of mixed up some of my dates. But basically, this is the first 4 months of the person's care. So it really should be April to August of 2022. The January, February dates there in July, those are really supposed to be between April and August. But suffice it to say that this was the first 4 months of this patient's care, and this really set the tone for how this person was going to be treated within our Diabetes Health Equity Clinic. Now, of course, within the first 4 months, you can't necessarily expect that we're going to have a dramatic decrease of the A1C, but what I'd like to show is how all of the elements were introduced very soon on in order to provide this person with the whole person approach and access to our team members. So they established care in April 2022. 2 days later, with the results, there was a call by the PCP, and this was a multifaceted call talking about the diagnosis, talking about the medications that would be recommended, as well as what I starred here as one of the significant points for this person's care is that the PCP talked about alcohol and talking about eating and drinking healthily. The patient mentioned overuse of alcohol. And right from that point, the alcohol and decreased alcohol recommendation played a significant part in this person's health because they literally didn't know how much it was affecting their chronic illness. So they get started on empagliflozin as well as naltrexone to help, so for a pharmacologic treatment for alcohol use disorder. They see endocrinology. They're still not having a point of care, still not having a really good control of their insulin, and it becomes apparent that at the next appointment that they really don't know how to use the glucometer too well. So this continuous glucose monitor is an excellent choice for them. This is my next star because I think meeting the patient where they were, this particular patient really was going to benefit from better technology in order to monitor his blood sugars and understand what's happening within his own body. We have a diabetes nurse check-in who is going to continue to talk about lifestyle changes. They soon see podiatry and are treated appropriately. They see optometry and are treated appropriately. And then this last star you'll see here in August 15th, a lot of things happened around this point that included an urgent care coordination referral because this person was having trouble with transportation. Their transportation was denied by the state, and they needed, it's because they didn't fill the forms out correctly. So remember, this is someone who had a traumatic brain injury and is going to need some more assistance. So this really puts the healthcare team and the care coordination team and everyone who's supporting this patient on the same page so that they can come to their appointments and they can get the care that they need. And then this last point here, we're seeing that the patient within 4 months is starting to significantly decrease his alcohol use along with the use of naltrexone. So this is the first 4 months, A1C 13.2 to 12.8. Now the next slide, and this is from then, August of 2022 to now. So you can see the dramatic decrease in the A1C with the graph here, and he ends up being having an A1C just a month ago of 7.2, has reached a low of 6.6 in the past, but is basically averaging at a well-controlled A1C between 6 to 7. So how did this happen? We checked back in with him in August of 22 when he was decreasing his alcohol, and then by September he was completely sober, and his A1C was 9.0, and at that point the CGM was placed. 3 months later, after the CGM is placed, his A1C goes from 9 to 7.4. And yes, the use of medications was used for insulin in order to titrate the dose in the appropriate way so that we would avoid hypoglycemia, but also get his A1C to where it needed to be. And you can see this is all a result of trusting relationships started at the very beginning with a team that is cohesive, that talks to each other, and also meets the patient exactly where he is. Next slide. To go into the details just a little bit here of the alcohol component, because I do think that for this particular patient, this is what was one of the turning points. From that statement, the scientific statement of the cardiovascular risk factors for type 2 diabetes, this was mentioned, and one of the studies referenced shows how significant a decrease in alcohol can affect your diabetes. So in the Addition Cambridge study, decreasing alcohol intake by 2 units per week, which is 20 milliliters of alcohol, over 1 year was associated with a 44% lower risk of cardiovascular disease over 10 years versus sustained intake in individuals newly diagnosed with type 2 diabetes. And now this doesn't necessarily mean that someone even has to be labeled with the alcohol use disorder, and maybe alcohol is not even a problem for them, but if they do make this decrease, we're going to see much better outcomes. Next slide. So you saw this patient who had a lot of obstacles, but had a team there to bring him from one place to the next in order to get his A1C down in a pretty remarkable way, in a very patient-centered way. So you might be then asking yourself, well, what if we don't have the resources, right? I'm just one person. I want my patient to get this care, but I don't have this team. So what do I do, right? So, of course, the Queen Elizabeth II said it's worth remembering that it is often the small steps, not the giant leaps, that bring about the most lasting change. And this is really true. So it's about, if you yourself want to see your patients in a better place, the first thing you have to do is educate yourself about knowing what it would take to get that patient to do what they need to do in order to optimize their health. So you educate yourself, and then you start to educate others. And then once you start to develop this team, you're thinking together, you're working together, and you're learning together. And you just keep repeating. So I wanted to just highlight one example of a resource that the ADA has that really exemplifies this approach for the whole person, as well as the team base. And this is the behavioral health and diabetes care. So the first module is engaging the whole person, is really what we're talking about here. The second one is an overview of behavioral health in diabetes care, because often if we don't ask about it, we're not going to know about it. So you have to ask about it. Then we talk about effective communication in diabetes care, and this gets to the essence of making sure the patient hears what you're saying in a way that they understand. Lifestyle, healthy eating, behavioral health. Then we talk more about behavioral health, anxiety, depression, and diabetes, because we know that increased stress and undiagnosed and untreated mood disorders will worsen chronic illness. So this has to be part of this. Then we have the screening, referral, and behavioral interventions. That's along the lines of using substances that are going to make it harder to stay in control. And then community engagement and behavioral health support. So that would be one resource that I would recommend people to go to if they don't already have other places that they're learning about this whole person team-based approach. So thank you, and I think we're ready for questions.
Yeah, fantastic. Thank you, Dr. Eligers. What a great case and a great presentation. We have a few questions from the audience here that we'd like to kick off on. They noted that one of the topics, one of the stars in your case study that you highlighted in this patient's trajectory was the CGM, the continuous glucose monitoring. So there's some questions around that in particular. The first one, just tell us a little bit more about your opinion on CGM's continuous glucose monitoring and remote patient monitoring in this type of clinic situation.
Absolutely. So I think, there's a lot of things to consider given, if insurance is an issue, if cost is an issue. But if we've found out that the patient indeed is eligible for coverage for a continuous glucose monitoring, I think basically what we want to do is figure out if this is a patient that needs it and wants it, right? Because even if they want it, that doesn't necessarily mean that they need it. So we don't want to, use resources inappropriately. But even if they need it, they might not want it. And so then you need to really, it's your job to show them why they might want this, why this might be of utility to them, right? So I do think that basically for the right time, for the right patient, this is absolutely could seal the deal with getting them their diabetes under control. But again, we just need to make sure it's a good match.
Great, thank you. Picking back off of that a little bit, any tips and tricks for us around getting access to continuous glucose monitors for those who are maybe uninsured or low-income patients?
Yeah, so that's the golden ticket, okay? So I don't have that answer. I think the first step is that you're at least recognizing that we have patients who are under-resourced. So if they're underinsured and we can't get this for them, then I don't have a specific tips or tricks or the secret password to get people the CGM. I know that what you want is a team of people that are constantly paying attention to the changes within the state or within the nation about insurance and maybe any other resources that they could use. So a lot of this does take creativity as well as a team of people that have the same goal in mind.
Great, thank you. I wish there was that easy button or golden ticket out there, and we'll hope that if you ever do find that, you pass it on to the rest of us.
Absolutely.
Yeah. So going back a little bit more generally, I noticed that your team at your clinic is varied and broad, and perhaps not all of us listening to the talk have access to that team-based clinic currently. So what advice would you give to folks who are listening to this talk and really contemplating on how they might get started in emulating your team-based approach? Where might they start?
Right, so that question is how to start.
How to start. Mm-hmm.
And I think it's good, again, when I say this team-based approach, when we think about who's our team, we think about, sorry, I was like hold my tissue there. When we think about who's our team, often you have to think about things in a way of not how to do it, but who to get involved, right? Because every organization is different. You're going to have the things that work well, the systems that have already been there. But if you don't have people on the same page with the same goal, it doesn't matter what systems are in place, it's not necessarily going to work. So instead of thinking about how exactly you're going to make it work, if this is something that's important to you and you think your institution is capable of, then first you want to convince yourself of how important that is, and then convince other people and see who else is interested. Then once you have a team, you can figure that out. So it's really, who first, not necessarily how.
Thinking a little bit more about the who, I'm curious if there are any other gaps or disciplines that are missing from the team that you've put together that you all have noticed with any of your patients.
Yeah, I don't think there's necessarily any particular area that is not there. Let's say with the diabetes nurse, though, for instance, She can educate on lifestyle, like on exercise habits and eating, but that she's not there with that person, reminding them to get up every morning and exercise, right? So I think what's missing here, if you talk about what element would really make this more robust, is if you had in order to make it self-sustaining, if you're able to get the community together, right? If you're able to connect the dots of some of these people getting the same care under the same roof and having them actually get to know each other and have a support system for themselves within the community, I think that's one thing that we have not been able to do since COVID. As there were some programs that were happening in terms of exercise classes and nutrition classes all together that were unable to be continued during the pandemic, and so we're still trying to rebuilding that. So that's what I would say would be the biggest area for improvement from us, is the community aspect.
Fantastic. Thank you so much for that. I think we are coming up on time. We do still have a few minutes. If anybody else has questions that they want to drop into the Q&A there for either Dr. Eligers or for Rana, you're welcome to in these last few minutes. One other quick question, maybe for both of you, Rana and Dr. Eligers, when we think about the care that you both provided, patients have to do the parts that you said, right? So the education, the patient has to comply, the patient has to be engaged. Any quick patient engagement tips that you might have for us?
I would just say, if you can find what is going to engage the patient is really what it is. We can't do these blanket things that we think this is going to engage the patient, because what engages one person doesn't engage another. Dr. Eligers' patient was obviously had a lot going on, but they figured out something that patient wanted to glom onto and really helped a lot of his ability to get better and better, so to speak, with his diabetes care. I think if we can do that with every single patient and really look at what is significant in each patient's life, that is where we're going to make it a difference.
I totally agree, Rana. And one of the examples that I use when you say we have to figure out what works for that particular patient, I forget where I learned this, but I do this almost every day. I ask one of my patients, I say, do you know what the best exercise is? And I let them just kind of sit with it. And they're thinking, oh, is it running? Is it weightlifting? Is it swimming? What is it? And then I say, it's whatever exercise you're gonna do. And that's it. And so again, that's a way to remind people that there's no cookbook. It's just what's gonna get them across their own finish line.
Fantastic. Well, thank you both, Rana and Dr. Eligers. At this time, I'll pass it back to Sarah to close us out.
Thank you so much. So I do want to thank you, our presenters and moderators, for leading today's webinar, and thank you for your participation in today's event. After today's webinar, you will receive a follow-up email with a survey on the presentation. We would appreciate if you would complete the survey and provide your feedback. In that email, you will also receive a link to view the recording of today's presentation. On behalf of the American Heart Association and our presenters, thank you for joining us today and have a great day. This concludes today's presentation.